you suture the wound for the secondary intention. You for the primary delayed, you give time for example 2 to 3 days. Secondary intention, you give time so that you debride, then you'll come and close later.
Okay. So just quickly try and answer this question. Great. Abdallah Kasim, what did you answer? Abdallah Kasim.
Um, I answered. I'm not sure of the answer, but I answered surgically debride and then close the wound in layers.
Do you have any reason why you chose that one particularly over the others?
Okay, I know that you're supposed to surgically debride, but I'm not sure if you're supposed to close the wound immediately. I
Okay.
think, yeah, you're supposed to leave it open.
So if a wound is more than 6 to 8 hours old, the best thing is actually it's not even about the surgical debridement. First, you just need to clean it even before you close it. However, you decide to close it. So that was just the point of that question. It's just for you to know that within 6 to 8 hours, because you'll see this a lot when you go for your internship, you'll be called to suture something. And then you need to find out how soon was it, because if it was within, if it's after the 8 hours, there's a high chance that even if you suture, you tend to have infection and you won't have a good wound afterwards. So now back to what we were to discuss.
Hi, Doc. Sorry, just a question.
Yeah.
When will you use activated charcoal?
Oh, we'll discuss that in the presentation actually today.
Oh, so thank you.
Okay. So what is wound care? What is wound care management? Wound care basically encompasses everything that you're going to do with in wound management, basically. So this is the only time you hear me talk about DIME. I'm sure you guys know what this mnemonic stands for. Um, The one we just spoke recently. What is dying? Mohammed. Mohammed Amin. What is dying?
I'm sorry, I don't remember.
Ah, okay, sir. It's a very common mnemonic. It talks about debridement, infection control, moisture balance, age. So this the only time I'll mention it because there are many things that come into wound management other than that mnemonic, and I'm sure that mnemonic is what you'll see uh, in so many places. So basically, the main goal is to ensure that the wound uh, becomes revascularized. You've removed all the dead tissues. If there's any infection, you get rid of it, and then you ensure there's optimum moisture. Okay. So our goals are to minimize infection, remove devitalized tissue, allow the wound to drain. That's if it's draining a lot of stuff. Promote epithelialization and wound contraction, improve tissue perfusion, and to ensure that there's adequate nutrition. This is very important, especially for burn patients who tend to have to be to be in a hypermetabolic state. So you need to optimize nutrition. Sawa sawa. So this is what we are discussing. This is the meat. Just these 13 things. If you ever get a question on wounds, be able to at least write all these three things. That's if it's an essay. If you have that, you will be good. So number one is promoting multidisciplinary approach. Number two is initiating patient and wound. So the initial patient and wound assessment is very important, and progressive assessment. The psychological implications of a wound, determine the goal of care. So those are the things that we are talking about before. You need to determine those goals in before you even start trying to take care of that wound. Respect the fragile wound environment, maintain a bacterial balance, maintain a moist environment, maintain a stable wound temperature. pH has to be controlled. Allow a wound to drain and remove dead space. And these are adjuncts. So number 12 and 13 could actually be put together, dressing and adjunctives. Okay. So we talk about the first one, and then the rest I'll get your input and see what you guys have to say. So we have to when you start wound management, you have to get a lot of people involved. You have to get a wound care specialist who tends to put all these adjuncts. You need to get a physiotherapist because sometimes we find that these wounds don't heal well. And last week I left you guys with some stuff that you guys can read afterwards for complications of wound healing. For example, keloids and hypertrophic scars. And we need to have contractures. So physiotherapists come really in handy, especially terms of moving those wounded areas. Nutritionists, you have to have optimum nutrition, counseling. Um, Ian Peter, why do you think we need a counselor?
Uh, this is because there might be some psychological aspects because of maybe scarring and
Sorry,
such.
we can't hear you. Keep breaking.
Oh, sorry. I'm saying
What did
there
you
might
say?
be some psychological aspects uh, to the wounds, such as the scars that the patient might be having.
I'm sorry, I can't hear you. Faith Ngeno.
I think it's important for counseling to happen because some wounds are chronic and they cause psychological stress, and also the part for cosmesis.
Yeah. And last week we discussed how psychological stress also impairs wound healing. So that's very important. Social workers are very important, especially in terms of putting this wounded patient back into the society and trying to figure out where they fit in. Family physician, if they have one, especially if they have other issues other than just the wound, then a plastic surgeon to try and close. Um, so the initial assessment will involve you can assess a wound in many ways. You can use the Bates Jensen wound assessment tool, or you could use the triangle tool. There are many tools that you can use. I think the Bates Jensen is actually the best because um, you will not miss out much. So from number 1 to number 13 comes from the Beth Jensen wound assessment tool. And then I've added point number 14 where we talk about order and the site. So the first thing when you get a wound is tell us where is the wound, and then you have to tell us how does the wound smell like. So there are different types of there's very strong whereby when you enter the room, it's evident that someone has an infected wound. Um, and then two, you can actually enter a room, but the dressing has been opened and that's why you can smell it. So in the first one is the dressing is there, but it's closed, but the odor is still there. Okay. And then you can have it whereby there's no evident smell when you enter the room, but when you open the wound, that's when the smell comes out. But you need to talk about the odor and where the site is. So the other important thing is talking about size. So size, we tend to use centimeters. So you take it can be irregular in shape, but just get the length and the width. That's enough. When you're talking about depth, we're talking about the layers. So it can either be partial thickness, skin loss, whereby we're talking about the epidermis and part of the dermis. Then you have full thickness skin loss, where it goes all the way to the dermis and even up to the subcutaneous tissue. And then you have even further damage, which is going all the way to the subcutaneous tissues, fats, the muscles, and the bones. So that bone is very, very deep. So based on that scale, you can actually give different numbers. So it's not for me to tell you you can always go and check it out. It's available. So you can go and check out where each one of those fits. For edges, we're talking about how does the edge of the wound look like? Is it clearly demarcated? Is it not clearly demarcated? Is it well defined but the edges have rolled over, or have they become fibrotic and hyperkerotic? So is it scarred? So those are the things when we're talking about edges. And then 4 is undermining. So undermining is whereby let me ask someone actually. Pauline Jockey, what is undermining of a wound? Pauline Jockey.
I'm not sure.
Okay, so usually if you have a probe, you can put it underneath the wound. So underneath the wound bed, you can actually channel through towards the edges. That's basically what undermining is. So you have different levels of undermining, and tunneling is actually the worst. So there are different levels based on the scale. And then we talk about necrotic tissue. Is it there? How much is it? How much area of the wound is it affecting? And what type is there? Is it a black eschar? Is it a hard black eschar? Is it a soft black eschar? Is there a yellow slough that you can easily remove, or is it tightly adherent? So those are the things that we're talking about. And then exudates, the same thing. What type of exudates do you expect? Evelyn Ndomo, what type of exudate do you expect from wounds? Usually about 4.
Pass.
Guys are tired from class. It can either be bloody, you can either have pus, or you can have serous fluid, or you can have serum mixed with blood. Okay, so that's the type you can expect, and then the amount again can range from nothing, a dry wound, all the way to copious amount of drainage. We talk about the skin around it. This is based on ethnic groups, but it can be highly pigmented to pink and normal looking. Okay, and then you have peripheral edema, which can go from non-pitting to pitting to crepitus. Then you have indurration, granulation tissue. So for granulation tissue, you have, let me show you, for example, in this one, you have a nice, even this one is right, nice bright red, even here. Okay, so that shows it's red beefy. It's ready to actually start healing. And then you can actually have it dull, red, and dusky. Even here you can actually see it in this particular area. This is not the same patient actually, but you can see it there. Or you could have no granulation tissue at all. So, and then you have epithelialization. So this is now when the wound is being covered up. This is when the wound now being covered up. So how much of the wound is covered? Is it 100% or is it less than 25%? So I'll start with let's see, Catherine Nyambuti or Lucy. Is she here? Silas Kiprop. Joseph Wafula. Is it that guys are not online? Is there anyone who's online? I want someone to tell us about this wound and what they think, all those aspects that we've talked about, other than order and of course, yeah, order specifically and size. Can someone give us those points?
Hi, Doc.
Yes, I can.
Uh-huh. With Michelle or
Chablokot can go ahead.
okay.
Okay, I can try. I can try on the in the wound in the right side of the screen.
Which one? The one for the hand or the one for the pressure sore?
The pressure source.
Okay, so tell us.
Yeah. So so for the site, it's found in the sacral region.
Mm-hmm.
Size is approximately the size is approximately 2 by 2 centimeters or 3 by 3 centimeters, around there.
Mm-hmm.
The edges are clearly defined.
Mm-hmm.
There's there's a plaque eschar.
Mm-hmm.
The, we are there are purulent exudates in the gauze that have dried.
Mm-hmm. Mm-hmm.
Yes, and then yes, I think someone can continue from there.
Maybe can you see the skin around it? What do you think of the skin around it?
Has it become fibrotic?
Not really. Don't. It's looking a bit blacker compared to the other side, so it's a bit pigmented. Yeah.
Okay.
Mm-hmm. So that's actually quite good. In terms of size, I don't think this is 2 centimeters. It's actually quite big. Probably around 10 centimeters. It's quite big. So the depth is also full thickness. Just under here, you could actually, on the actual patient, you could have actually palpated the sacrum. The edges are well clearly defined, as you said well. In terms of undermining, even by looking at this image, you can see right here, you can actually tunnel through. So tunneling is happening there. What else? In terms of necrotic tissue, there's minimal necrotic tissue. It's actually more of yellow, but not as much. As you're saying, there's some black esca there. So that's more of a 4. And then in terms of how much necrotic tissue is there, you can say around quarter of the wound is affected. Is there exudate? Yes, you see those exudate scans, but on the gauze, as you said well. The skin around it is hyperpigmented, it's becoming black. You cannot palpate, but when you palpated here, there was edema. Okay, and it was spitting edema. There's induration as well. Granulation tissue is barely forming here. So it's dull and dusky. And epithelialization has begun, especially over here, but it's less than 24%. So those are some of the things that you need to be able to say. Michelle, which one did you want to take out of the other two?
The middle one.
Okay.
The site is on the dorsum of the foot. Looks like the right foot.
Yeah.
The edges are clear. They're well defined. The depth is, I think it's partial thickness. It's only involving the epidermis. You can see granulation tissue covering almost 100% of the wound. The size, it's around 50 meters in length by maybe 6 or 7 in width. There's no necrotic tissue.
What about this? It's a very small one though. The block is.
I thought that was part of skin.
That's something else. But okay, yeah. You're doing well. The only thing you've not talked about is undermining and exudate in the skin around the edema, induration. Maybe you can make a comment on those ones.
The surrounding skin looks edematous and hyperpigmented slightly, yes.
What about
there's no exudate.
There's a bit of exudate over here in the gauze only.
Yeah.
What about the undermining? Is there any undermining? Do you think there's any undermining there?
I'm not sure.
So there's not. This wound is it's very close to the edge, so there's no undermining. Even if you check the other sides, all of it is well opposed to the wound. If there is, you'll be creating it. That's a good attempt. Very good. So you can practice on this one and this other one, and try and be able to assess wounds quickly, so that you can easily know the problems. This was part of the
excuse doc.
Yes.
But
in the bed. So how did you describe the undermining edges? I didn't listen properly.
Oh, so this one is definitely tunneling. You can see there's a huge hole going through to the other side. So there's oh, you're asking what tunneling is, or are you asking whether there's tunneling in this picture?
Like how will you describe the parameter of undermining edges, undermining skin? Like
the tunneling, the undermining. So when you're talking about undermining, so the scale is basically how far does the wound bed go underneath the wound edge. That's basically it. Okay. So it's tunneling, so you can easily go through. They say around more than 4 centimeters through. So this one is definitely more than 4 centimeters through. Or you can be going more than half the wound margin. So that's around 2 to 4 centimeters. Or you could be going less than half of the wound margin. So that is minimal tunneling. And then there's also less than 2 centimeters, which is barely any tunneling. So usually even that is most of the time you can actually create it yourself. So like for example, this one for the hand, you'll find that there is minimal tunneling. So this one could be around 2 centimeters. If you put like a toothpick here, of which it's usually more of a probe, it can go through. It can go through in this particular end, but it's not going through to the other end. So in tunneling, if you enter here, you can feel your probe on the other end. Hope you've understood now.
So how do you describe it? Like
So it's either it's there or it's not there, and then now you give it the distance. So 1 centimeter, 2 centimeters, 3 centimeters, like that.
okay, fine.
But if it's more than 4 centimeters, it's officially tunneling. So it's like
Sir?
a tunneling, a tunnel.
Okay.
Yeah.
Fine. Thank you. Thank you.
So you can use the remaining images to practice, plus this ones. This is even a repetition. Um, so yeah, we already spoke about this. Why should we consider a psychiatrist? So this is the second point. Mm, but the main goal is to ensure that the patient is well motivated, and they're going to take everything you're going to tell them. So if it's dressing, coming for multiple dressings, if it's because it's infected, taking the antibiotics, optimizing glucose, all those things. Um, that is what you want. Okay. Vincent, do you guys
So
have
so
someone who's doing a diabetic foot from the tutorials?
yeah, we have. I thought you said among us. I think there's diabetic foot.
Yeah, from the orthopedic guys, Yeah, so
Yeah.
this is a very important thing. You find that a lot of diabetic foods they really struggle. So the psychology has to be sorted out. Um, so you need to determine the goals. We already spoken about the goals that you need to have, and you need to bring both the team that's going to manage plus the patient. So it's a shared decision making protocol where you're bringing in both the patient and the team, and you actually deciding together. So this is our goal. Our goal is 1, 2, 3. We want to optimize the sugars. We want to ensure the infection is gone, and you want the wound to have covered up by X date, and we want you to be coming for X number of dressings. Is that possible? Is that not possible? Why? What can we do to help? That's basically what this slide is about. So we talk about respect for the fragile wound environment. You have to understand that the skin has been broken. So there's a chance of multiple infections. So you need to prevent infection, especially if it's a chronic wound that has been open for a very long time. Or if it's a dirty wound, and we talked about what a dirty wound, contaminated wound is last time. Um, you have to be aware that limb loss or finger loss or whatever can happen as a result of poor management of wounds and worsening the whole situation. So all these things you have to do preventative measures, especially for those people with chronic wounds. Another very important thing is such wounds, because they tend to be open, the epithelium is out, and the dermis is exposed, you tend to have a lot of pain. So you have to be very good in terms of wound management. Yeah. So can someone tell me the WHO stages of wound or the WHO guidelines in wound management? Someone, I'm seeing here is Crystal Mary Kagai. What is the WHO pain management protocol guidelines?
I'm not too sure about the steps, but I can try
Mm-hmm.
talk about the okay, it starts with the ABC protocol. Then I would manage the pain by giving analgesics.
Mm-hmm.
Then tetanus prophylaxis,
Mm-hmm.
and give antibiotics,
Mm-hmm.
um, and then okay, maybe take a picture of the wound, um, and then I'd consider taking the patient for radiological imaging, maybe if there's a fracture.
Mm-hmm.
Um, and then I'd cover the wound and maybe plan to take the patient um, to theater for maybe irrigation and debridement.
Okay. But in terms of the pain, what would you do? Which because that's what I'm asking. What painkillers do you start with and why? Or which painkillers do you start with when you first meet the patient? Because they usually
This
tend
is
to
the
have.
NC.
Sorry.
I'm not too sure. I'm not too sure about that.
Okay. I've sent Vincent the ladder that I'm talking about. So usually start with simple analgesic. Sorry. Um, so either paracetamol or an NSAID, ibuprofen, whatever. And then if that doesn't work, you go to step number two, and that is a weak opioid, which could be codeine. You give another, so now you combine with ibuprofen and paracetamol. So you usually find combinations of that. So at this particular point, you're still giving orals. In stage three, you give a strong opioid, and then you still can still give the other uh, simple analgesic and adjunctant. So you can give now paracetamol IV, you can give diclofenac IM, and then you can give a morphine or pethidine. So now it's a stepwise approach. So you start with the simple ones, and then you improve. So if the patient is coming as an outpatient, you can easily get away with giving them aspirin, paracetamol, or any other NSAID as an oral medication outside, or even the COX. Is it COX-2 inhibitors? You'll be fine. Um, but if that doesn't work, then you need to add a weak opioid, um, which will work on the, and you see whether the pain is controlled. If that doesn't work, then you might actually have to admit and give them in a hospital setup, and then when that is controlled, now you switch over to oral medication. So that's what I mean by pain management. So anytime you ask about pain management, throw in that WHO, it's called the WHO pain ladder, and you can easily now, it like they even know what you're talking about. It's a stepwise approach. Okay. Last week we talked about bacteria, and and we know that the bacteria tends to cause the smell. So sorry. The gram-negative bacteria are the ones which are causing the smell that is either too strong, or just a bit weak, but it's the anaerobic bacteria. So how do we manage that wound? So someone asked at the beginning, why do we activate charcoal? Activated charcoal tends to reduce the smell. But in terms of wound management, the first step is sorting out the infection. Last week we talked about contamination all the way to a systemic infection. I don't know whether someone can quickly just remind us, Gasheri, Damaris, Gasheri, can you quickly tell us what it was? Or Doris Kilonzo? Ahmed Swaleh?
Come again, can you please repeat
I'm asking,
the question?
well, last week we talked about contamination, colonization, local infection, spreading infection, and systemic infection. I just wanted to know, what did you say they were, quickly?
Repeat.
No. What was for example? What is contamination?
It's about the wound.
Mm-hmm.
If it's contaminated itself, then it's like a ladder that the last stage will be systemic infection caused by the wound itself.
But what did you say it was last
Okay.
time? Okay, so you guys can go and check that out. Remind yourself because we talked about them last time. Um, for colonization and contamination, we don't need to give you infection. Um, and then for local infection, you can give a topical antimicrobial. I remember, yes, last week someone asked which antibiotic do you use and which one have worked in my practice. I remember that question. But it depends on where you are on this spectrum. Okay, so you can get away by giving silver dressings and they'll work really well and actually debride. And these ones will be quite okay. But once you get to the spreading infection and systemic infection, you have to give systemic antibiotics. So you have to give your ceftriaxone, you have to give your amoxiclav IV at this particular point. Okay. Um, but you also have to you have to cover for the gram negatives by giving, like, for example, metronidazole or other things, just to ensure that you cover for both sides. I think we'll talk about this. I don't know whether it's next week, but one of these weeks we're talking about soft tissue infections. And sometimes, even majority of the time, actually, they tend to be polymicrobial. So you need to cover for both. Um, so again, we talked about the yellow slough and the black slough and the black eskers. So one thing that I need you to go check up on is the principles of debridement. So there's the red, yellow, and black system. Go and find out what that is and why it's important, especially when you're debriding wounds. Um, in terms of wound management, you have to ensure that there's optimum there's a nice moist environment. Okay, because if it's too dry, there's a high chance of you injuring again when you're removing the dressing. If it's too wet, then you're accumulating the matrix enzymes within that fluid, which is continuously breaking down the extracellular matrix and the collagen that you've deposited. So you're doing nothing, and they call that maceration. Okay, and that impairs wound healing. So you have to have a nice optimum moisture balance. And this one you have to constantly check on your wound. Okay, so there are different there are different dressings, and different dressings are used for different occasions. So there are some which are used to increase moisture, there are some which are used to remove moisture. I think you can get this. It's good that you guys have because up to date, but there's a table in up to date where you can actually get um, what each dressing is for. Okay, so discussing each one of them will might be too taxing. So the next thing is temperature. Extremes of temperature are bad for enzymes which are involved in wound healing. So you don't want any extremes of temperature. Again, extremes of temperature tend to cause burns. So it could either be what do you call this, a frostbite, or it could cause a thermal injury. So you don't want any of those. I told you this guy this week is very easy. You have to maintain an optimum pH. So you have to respect the pH balance, because again, for the enzymes to what do you call this, to work. So what you're using on the wounds, you don't want to put, for example, what is this thing called that a lot of people tend to use even at home. Hydrogen peroxide. You just don't pour it directly on a wound, and you're thinking that you'll be debriding the wound chemically. That does not help, because now you're creating a very basic environment, and that will not work for some enzymes. Okay, so you have to be very, very aware. Again, some drugs tend to have sulfur, and then when sulfur is combined with like water and all, that tends to form a weak sulfuric acid in that particular area, then causing an acidic in the environment. So sulfur sometimes is in combination with some drugs that you're putting on the wound. So you have to be quite aware of all these things that you're putting. You have to have an optimum pH balance. Okay. Again, if a wound is leaking and is removing a lot of fluid, allow it to drain. You don't need to put like 10 dressings or cover it. You allow it to drain. The only time you don't allow it to drain per se is when it's bleeding. That's when you have to, but that's not draining. Draining is when the exudate is coming out and pus is coming out. Allow it to flow freely. Okay, that's a self-explanatory statement. Uh, the other part is eliminate dead space and do not pack tightly. So when you go to Kenyatta, you'll see that the nurses tend to put loose, flexible materials which fill the entire depth of the wound, but they don't pack it tightly because packing tightly, what would it cause? What do you think it will cause, Dorcas Atino?
I think it would impede blood flow to the
Mhm.
tissue, and yet that is what we really need so that this wound can heal. That
Exactly.
will,
You're causing pressure, you're funging all the blood vessels, and nothing is getting to that point. Exactly. So you need to allow for movement, but don't leave dead space. So the ideal dressing that you're going to choose is all these factors here. I think you can go and read on your own. It's something that basically absorbs fluid when there's excess fluid. You need something that is prevents infection, something that protects the wound, something that easily can be put in any conformation of whatever wound you have, something that can easily debride the wound. So this um, is the girls that you tend to find in the wards, especially in the public setup. Most of them are very good at debriding wounds, but there are better ones, of course. You don't want one which is too wet that will disturb the wound edges. Um, Eliminates pain, although I've not found one which eliminates pain, but yeah. Um, and then one that you not be hypersensitive to. And what there's a concept called primary and secondary dressing, whereby the primary dressing is the dressing that is attached to the wound, the secondary dressing is the one attached or securing the primary dressing. So that the concept of having both of them allows you to check on the wound but not open the primary wound covering. So you can always confirm because most of the time you'll find is that the reason we constantly open wounds is because the dressing that we are using does not allow for reusing. For example, the first image I was showing you, the dressing that we had is already dirty, so you can't reintroduce this dressing back on the wound. So you have to put a new fresh wound, new fresh dressing on top. Okay. So it has to be affordable. I think majority of the ones in Kenya are affordable, but the expensive ones are the ones which tend to do majority of these functions. Transparent for you to monitor the wound progress. So go check out this at your own free time and understand what it's all talking about, and then check out on up to date the different dressings that you have because there are many. You have so many. Again, even when we're talking about order management, I don't know whether we talked about it vizuri, but the first thing was we said we're going to check the infection. The next one is you have odor controlling dressings. So there are different dressings that can be put that actually reduce the the odor of the wound. Okay. I think there are like three of them. There's one which has activated charcoal in it. There's one which has algae within calcium alginate within the padding of the dressing, and then you have foam dressings. So there's so many dressings that are there. You can go and check them out. There's so many, and why each one of them. So you can literally create a table showing these dressings are used to increase like hydrogels to increase the moisture, and then you have others which reduce the moisture, others which tend to be used when it's infected. So all these can actually be well summarized. And then adjuncts. So when you're actively managing a wound, and this in this case you have all the utilities that you need, then you can improve the timings for wound healing much faster. So we have multiple adjuncts. One of them is dressing. The second one is now pressure distribution equipment. Let me ask Doris Kilonzo, what do you think pressure distribution redistribution equipment is?
Um, Pressure distribution material.
Hmm?
Okay, going from the name, then it's probably material that distributes pressure. Not too sure.
Like people with pressure sores, what type of mattress do you tend to say that you
Oh,
want
okay.
to prescribe?
All right. Soft mattresses, the ones that like sink in, so that
Mhm.
it's not like pressing hard against the ischial to rest.
What else? What is the name that they give those mattresses? I'm sure you've had it in the word
They're
somewhere.
called, yeah, they're called,
Let me put an image.
uh,
Maybe you remember this mattress.
I don't know.
Ripple mattress.
Sorry?
Ripple mattress.
Yeah, ripple mattress. Okay, so that's what it is. And then you have offloading orthodontics. So this type of boots, especially for diabetic patients. We talked last week and said that because of motor neuropathy, they tend to have pressure necrosis because of how the foot is is positioned because of that neuropathy. So you put this to relieve that pressure on those areas. Okay. Um, Again, negative pressure wound therapy. Can someone tell me what negative pressure wound therapy is? Is there anyone who knows what it is? Has ever heard of it? Has anyone seen it? Okay. So,
Would it be the one that continually suctions
mhm.
to so that there's no dead space? To create a vacuum.
Yes, yes, yes. So this one, the one on the bottom left, I don't know that it's this one, eh? Bottom left. So what they do, what tends to happen is the wound specialist, uh, they put a device which controls the application of pressure around the wound, around the granulation tissue. And this assists in debriding the wound and creating a sterile barrier. So you're preventing the infection and you're debriding the wound. And at the same time, because of the negative suction, it promotes granulation tissue formation. Okay. So the negative pressure that is created by the suction, yeah, the suction from this tube, um, that negative pressure um, removes blood, serous fluids from that area, removes also the purulent exudates, and also because of that suction, the blood vessels are now opening up and there's increased blood flow to that particular area. And this improves deliverance of oxygen and nutrition. Because of that, you tend to have accelerated wound healing. So for acute wounds, you tend to use higher pressures, and for chronic wounds, you tend to use lower pressures. And this, for chronic wounds as well as skin graft, this helps healing of the wound, and it's a very important adjunct, and many people are using it. So you have splinting to also prevent excessive movement of limbs, and I'm sure the orthopedic guys have talked about splinting. And then you have I wrote compression there. Just forget about it. But there are many others. So also there's hyperbaric oxygen therapy. This is something that is coming up where you expose the wound to oxygen, a lot of oxygen, and that helps rejuvenate the wound. So It's new technology that allows quick. Okay, that's it. Quickly answer for me that question, and then we can call it an evening. Uh, um, I'm seeing one person put extremes of temperature interfere with the enzymatic reaction in wound healing. Where do they think that's the answer? Does that person feel like sharing?
Yes.
Uh-huh.
Uh, okay. At first, I used the elimination method.
Mm-hmm.
If I start with the first one, with the first one,
Mm-hmm.
which says it's important to include the patient in your selection of wound rest. That's very true.
Mm-hmm.
And then this one that says a purulent wound with thin or thick something require antibiotics is very true.
Mm-hmm.
And then this excess wetness causes re-injury during redressing is very true because uh, I think that is where when there is a lot of wetness, more enzymes are produced and it causes injuries against the wound.
Mm-hmm.
So the last one is the answer because uh, yes, extreme of temperatures. Uh, I think it is the mechanism that is wrong here. Like you don't require enzymatic enzymes. You don't require enzymes in wound healing, like Vile. Yeah.
Mm. Okay.
Yes.
Okay. That's okay. That's good points. Let me hear from someone else. One of the guys who chose a purulent wound with thin or thick, opaque, tan yellow pus with or without odor requires antibiotics. Anyone choose that? Out of the five people, no one is brave enough to tell us why they chose that one. Okay. So the answer for this one is excessive wound causes re-injury during redressing. So the reasons you gave were somewhat right, but excessive dryness is what causes re-injury, not wetness. Wetness causes maceration of the wound. Okay, not re-injury. Re-injury tends to happen more with dry because every time you're removing the dressing, it tend to cause injury. But with a wet wound, it won't cause any damage. But enzymes are very important. They're very important in wound healing. We talked about um, chronic wound healings. Chronic or impaired wounds. Impaired chronic wounds with impaired wound healing, and we say that one of the features is elevated levels of proteases enzymes, which are breaking down the collagen. We need enzymes for remodeling, and we need enzymes for what do you call this, during the proliferative phase of wound healing, and mostly also, but most of the time it's more for the remodeling phase. So that those things, so enzymes are very important. Okay, at the same time we also have neutrophils. They have vacuoles within them which now destroy phagocytosed materials, the foreign bodies, the bacteria. They are broken down by what? Enzymes. So enzymes are very important in terms of wound healing. So extremes of temperature interfere with those enzymes, starting from the inflammatory phase all the way to the remodeling phase. So you need enzymes. Okay, I hope that is now clear. So I've sent a link to the group just showing you now that I know that you guys are up to date. There's a table that now gives you the type of wound, the therapeutic goal, the role of the dressing, and the type of primary and secondary dressing that you will use for those types of wound. You'll see that it's a robust table, or it's a table that you sit with and you try and understand everything. If you sit here and discuss all of them, we'll finish tomorrow. Okay. Sawa sawa. Any questions? Okay. Is Vincent here? Or has he left? So I'm assuming everyone is good. No question. Last time, I think Diana had a lot of questions. Today she's very silent. Are there any questions? None. So. There's a form that I've sent. There's a form that I've sent. Vincent, you guys can fill. Although I say that I usually pick the attendance with meet attendance. That's what I use. And I'm seeing here only 61 of you attended. So, hiya. So you guys, I will activate. If you have any questions, I gave my details last time. You can always contact me on those spaces. Thank you.
Thank you for the lecture.
Thank you.